just to get a real background on COVID, can you tell us about the virus? How does it affect people? Why is it so deadly? How does the Delta strain compare with the original virus? And is it inevitable that we will all get exposed to it sooner or later?
Yeah, so COVID in a nutshell, essentially.
Yes. Tell us everything.
Yeah, sure. So I think we're all familiar with the basics of coronavirus or COVID-19 and how it spreads. I think what a lot of people don't realize is that there's a very broad spectrum of disease. So some individuals will get a mild infection, whereas some individuals will get a severe infection. We now know quite well some of the factors that are associated with a severe infection, things like old age, and I'm talking not that old. Basically, once you get over 50, your risk increases. Males, unfortunately. Then we know things like diabetes, obesity, all those things increase the risk of severe COVID. And when I talk about severe COVID, do not think that this is flu. I've worked on flu for most of my career. And if you look at the lungs of a COVID patient and you can take them out and you can actually look at them in a lab, they are so destroyed, they do not even look like lungs. If you showed them to me blind, I couldn't tell you that they were lungs. I would think maybe it's a piece of liver or something like that. That's how decimating the virus can be. The problem we have with this virus on top of this is that even though the young may get a mild initial infection, we now know that there's a phenomenon called long COVID, whereby individuals continue to suffer various signs and symptoms of COVID as little as 4 weeks post-infection, all the way up to 1.5 years post-infection. This occurs even if you had a mild initial acute infection. And we're actually doing a study on this. So talking to patients with long COVID, we're hearing testimonials from people who were young, healthy healthcare workers who contracted the virus in the first wave in Melbourne, who still a year later cannot go back to work because they simply don't have the energy. So this is, I cannot emphasize it enough, a serious disease for everyone. We have variants emerging with COVID-19. There's lots of different variants and it gets very confusing with the naming. Even us virologists get confused. The one we're focused on now is Delta, because that seems to be the dominant variant in the world. We know that Delta is much more transmissible than the original ancestral virus. It's still very controversial as to whether this virus actually causes more severe disease than the initial ancestral virus, and that's something that we're actually actively researching, but we do know that it's more transmissible. The other thing and the other problem, I suppose, we've had in parts of Australia is that we've been victims of our own success. In Queensland, in WA, in South Australia, we haven't really had widespread COVID outbreaks. So we don't really know what it's like to go through that. And if you talk to friends and colleagues who've gone through that in Melbourne, in Sydney, but also overseas, these are pretty horrific times when you have, basically, I've talked to a clinician colleague in Indonesia who at one point in the pandemic, their hospital ran out of room to store the bodies and they were renting cooler trucks that were just lined up outside the hospital to put the bodies in. So with all that in mind, at some point, we are going to have to open borders and we are going to have to let COVID in because we cannot stay with our borders shut forever. That's just not feasible. The difference is, do you want to get COVID as an unvaccinated, vulnerable individual and sign yourself up for all those consequences that I talked about? Or do you want to get it as a vaccinated individual where even if you do get an infection, it will be mild, your risk of long COVID is low, and importantly, you're at a very, very low risk of having to go to the hospital or dying from the disease.
You've mentioned to me before your role at UQ is actually researching COVID and developing cures and vaccines. Can you explain the vaccine to us, how it's created? Did we shortcut the testing of the virus or did we just speed it up? How does the vaccine reduce the risk of transmission or death? And how would you rate the different vaccines? I've taken Astrazeneca. Should I get a Pfizer top-up later? What's the latest on that?
Yeah, so the essential way any vaccine works is it tricks your body into thinking that you've had the infection without getting you sick. So basically it means that your immune system mounts the appropriate response as if there'd been an infection, but you don't have all the consequences of, having to go through the illness itself. Now, there's different variants of these COVID-19 vaccines that work on different platforms, but that's the fundamental principle across the board. Vaccination, incredibly, and I think people don't realize how incredible this is we've got multiple really good vaccines against COVID, okay? It is really tough to make a vaccine, and to get multiple good vaccines against a virus, it puts us in a really good position. Some people have been really concerned that they were done too fast, because it is the fastest time we've brought a vaccine from development to market. But I think what people need to realize is, first of all, we in the virology field knew a pandemic was coming. This was not a surprise. I actually have in my house a designated pandemic box that I've had for the last few years, knowing that a pandemic was coming. I haven't used my pandemic box yet, but it's still there just in case. So this was not a surprise. We knew that we needed vaccines, and specifically vaccine platforms that could be rapidly adapted in the context of an outbreak. So it's not that this research represents 1 year of research. This actually represents about 20 years of vaccine research. On top of that, what you normally do when you're developing a vaccine is you do something like a phase 1 trial, you then collect the data, you present the data, you go around to funders, try and get somebody interested, then you can get funding for a phase 2 trial, go around to funders, get funding for a phase 3 trial. And, it's a long process. In this situation, we had so much money being thrown at the vaccines that, provided the data looked good, there was no problem progressing on to the next stage of the trial. And then the final thing to note is that actually manufacturers took an incredible financial risk with these vaccines. Normally, manufacturers only start manufacturing a vaccine at the very, very end. Once it's all been approved, everything is good to go, and then they will start the manufacturing process. Here we had manufacturers start manufacturing basically around phase 1. Now, this is an incredible risk to a manufacturer, because it means potentially they're generating thousands and millions of vaccines that will never be used. But it is preventing a lag at the end of the vaccine making process. So what you'll note with all of these is that these are ways to create shortcuts or shorten that time, but at no point is any of the safety or the efficacy compromised. They all remain very, very tightly regulated. We have different vaccines available now in Australia. We have Moderna, Pfizer, and of course Astrazeneca. Astrazeneca obviously copped a lot of bad press because of the issue with blood clotting. But for individuals who are over the age of 60, over the age of 50, it depends a bit on the country, who are at low risk of the blood clotting, AstraZeneca is a great vaccine. Pfizer's a great vaccine. Moderna's a great vaccine. And the reason they're all great vaccines is they all have incredibly high efficacy of keeping you out of the hospital and keeping you from dying. And that was the goal. The next generation of vaccines will do things like looking at preventing transmission, and these vaccines already do prevent transmission, just not perfectly, and maybe looking at things like oral administration, so you don't have to have a needle. But the vaccines that we have are incredibly good, and what I've been telling people throughout the pandemic is just get whatever vaccine you can get. So, if you fall into the older age category and you're eligible for AstraZeneca, get AstraZeneca. If you're younger, get Pfizer, get Moderna, get whatever, just get yourself protected.
There has been an argument about whether 80% is enough for Queensland and WA to open. Can we get their medical opinion on what will happen if we had no cases in Queensland, we've got 80% double vaccinated, and we did open the borders to other states? Would our hospital system keep up? Would we be in carnage? Is it going to be enough?
This is a key question. And look, I'm not privy, as a virologist, I'm not privy to the sort of ins and outs of the healthcare system and what the hospitals are indeed capable of. My concern is that we will get COVID cases if we open up. There's no question about that, because 80% is 80% of those who are eligible. So we also have a lot of kids who aren't vaccinated. We also have a lot of people who just adults and not vaccinated, it is going to be a test. And that's a pretty scary thought. So in my mind, the way to mitigate the risk there is to have more people, as many people as possible vaccinated when we open the borders. So yes, okay, there's this 80% goal, but let's try and exceed that. Let's go 90%, because that's the only protection we have against our hospitals being overwhelmed. And we won't really know what we're facing until we face it.
I've heard the theory, I think it came out of Michaelia Cash's comments one day around, once we get to 80%, the borders have to open up because this is no longer a medical emergency. Do you have an opinion? I think you've already answered that in the negative to me earlier.
Yeah, I think, look, I can't comment on any of the legal requirements or anything here, so I can just contextualize the healthcare requirements. I think we need to have certain things in place, because it's not just going to be, when you look at countries that have opened borders and reduced restrictions at 80%, they haven't just done it based on vaccines. There is still social distancing. There is still actually a clear need for rapid antigen tests in Australia that for some reason we are years behind, and I don't understand why. So that needs to be implemented broadly. We also need to have better use of things like monoclonal antibodies. So if people do get infected, there is therapies there available for quick treatment. These are all things that I would consider in addition to the vaccination rate as to whether or not we're ready to open.
Excellent. While I've got you, we do have a member's question around vaccines and some of the myths, truths getting around there. Are all three vaccines built on the same technology? I heard Astrazeneca was very different to the other two. Can you break that down for us?
Yeah, that's correct. So of all the myriad of different COVID-19 vaccines, there's different technologies used. So Pfizer and Moderna use an mRNA technology. So this is the newest technology. And this is, I guess this is the first time in an outbreak we've seen this technology used, but it's very, very effective, and it's based on decades of research. The AstraZeneca vaccine is based on slightly older technology, although it's not old technology, where basically they've taken a harmless virus, engineered the virus to express one of the proteins of the coronavirus, and then the body is tricked into thinking that, hey, I've been infected with this coronavirus, when in fact they've just got this harmless virus carrying a protein of that virus. This is relatively new technology, but this is actually the same technology that was used to roll out in the Ebola outbreak in West Africa, and that was the vaccination strategy used there. So they are different strategies and different platforms, and that's why we see different complications. So we see a blood clotting complication with AstraZeneca that we don't see with the mRNA vaccines, and that just simply reflects the different technologies used.
So I've also read that in Europe, they've been crossing the streams, giving people a different vaccine. And I had a question earlier there. Am I going to get a better protection from getting even a third booster shot from one of the other vaccines?
Yeah, so this is something that we've known in vaccine development for a long time, and this has been actually the cornerstone of HIV vaccine development, which is a virus that's very, very hard to vaccinate against. We know that mixing and matching vaccines typically, and I'm talking about mixing and matching platforms, typically gives you a better immune response than if you stay with the same platform. So what I would suspect is that probably we're going to have mRNA boosters for individuals who need boosters. And that's actually going to be particularly beneficial, because the individuals who are most likely to need boosters are those who are older adults, those who have underlying conditions. So those individuals who probably were first vaccinated with AstraZeneca. I mean, it would be fine if they had the Pfizer vaccine first. It would still work beautifully. But if you happen to have had the AstraZeneca first and then you get an mRNA booster, you're just in a slightly better position.
So are we likely to end up needing a repeat vaccination every year? Do we know the longevity of the vaccines at this stage?
We don't know that at this stage. I personally think, well, what you see now in the US and the UK is that they're boosting vulnerable populations. Israel is boosting everyone. which I don't think is probably necessary at this stage. The data is suggesting that over time, the efficacy against hospitalization and protection against death stays really good. But what does seem to go down is your protection against actual infection. So this then becomes, the booster question is a very complicated question, because potentially if you boosted everyone, you may actually have a better effect on transmission, and that would be really good for the society. But how do you weigh that up with the ethical obligation you have of boosting a population when in Africa, with the exception of South Africa, about only 1 to 2% of the population has been vaccinated? And that's not only bad from a humanitarian point of view, but any place you have a raging COVID outbreak, you have the risk of new viral variants emerging that can then come back across and evade the vaccines. So to do that balance is very, very difficult. So I would suggest at the moment it should be targeted boosting for those vulnerable populations and the younger individuals until we have actual real data that it's waning in these individuals. It's not justified. You know, one of the things that baffles me about this misinformation is I look at what I'm an expert in, and, you know, I've literally spent my professional career in infectious disease, emerging viruses, pandemic preparedness. Like, this is what I do. But if it comes to doing anything with wiring electricity, for example, building a house, anything along those, I'm completely hopeless. So there is no way I would do a quick Google and be like, how do I rewire my house? Okay, I've got this down, and then go try it. It's just not how it works. I would go to an expert, and it's no different in a medical situation. We have experts in our society for a reason. One of the other things that I would just advocate is one of the tools that we've been developing is actually an online risk calculator for people who can go in and enter in their age, their sex, eventually their comorbidities, and then what the rate of community transmission of COVID is in their area, whether it's Delta. And then it will tell you what your risk of getting COVID is, what your risk of dying from COVID is, how that changes if you're vaccinated, and how that relates to other risks we have in our daily lives. So, you know, our risk of being killed in a car accident, which is something we probably don't think about on a daily basis, but it's still a risk. So we're also developing these risk benefit analysis tools that we hope will help the public better understand the benefits of vaccination.
But Dr. Short, if I can just paint a picture into the future, and if we can look ahead into a year's time, when hopefully we've got high vaccination rates and hopefully being fully open, where do you think we'll be with the virus? Is there a risk of other strains or other developments? Will it be a thing of the past around that time?
This is all going to depend on what happens globally. So we talk a lot here about the situation in Australia, but if we just get the vaccine rates up in Australia and we let COVID run rampant throughout various parts of Asia, throughout South America, Central America, then we are going to get more variants emerging and they will threaten our vaccine-induced protection. So I'm hoping the next stage, once we get vaccinated, will be a targeted global effort to get the vaccines to those who may not be able to afford them or those who are difficult to reach in a vaccine program. And that is how we end COVID.